Good afternoon. My name is Ian Culbert. I am the Executive Director of the Canadian Public Health Association, and I am very pleased to welcome you to today's webinar entitled Supporting Refugees in Canada Through COVID-19 and Beyond. Before we get started, I just want to acknowledge that while we are all gathering on this Zoom platform from different parts of Turtle Island, I am participating today from CPHA's offices in Ottawa, which is on the ancestral and unceded territory of the Algonquin and Anishinaabe peoples. In light of what is happening in our country regarding Indigenous peoples, from Joyce Echawan to the Fishers in Nova Scotia, we need to have this constant reminder that we need to be in partnership with Canada's Indigenous peoples and working towards better solutions that will support their health and well-being, respecting their rights, their access to the land and to the natural resources. And CPHA is committed to meaningful truth and reconciliation with all Indigenous peoples. I am very pleased this morning to be able to introduce to you as I go to my correct page, our presenters this morning. Dr. Gabriel Fabreau is a general internist who provides medical care at the Peter Lougheed Centre, Mosaic Refugee Health Clinic, and East Calgary Health Centre in Calgary. He is an assistant professor in the departments of medicine and community health sciences at the University of Calgary and a member of the O'Brien Institute for Public Health. He co-directs Refugee Health YYC, an O'Brien Institute Research, Education, and Innovation program focused on improving health and healthcare for recently arrived refugees to Canada. Dr. Annalee Coakley is a clinical assistant professor in the Department of Faculty Medicine at the University of Calgary. She received an Alberta Medical Association Award for Compassionate Service in 2016 for her dedication to local refugees. She is the other co-director of Refugee Health YYC and is a recognized national leader and advocate in refugee health and refugee healthcare in Canada. She also teaches immigrant and refugee health courses to Cummings School of Medicine undergraduate students. So just a couple of notes before we get started. Today's session is being recorded and will be posted to CPHA's YouTube channel later this week. You're welcome to ask questions, but please do so using the Q&A module, not the chat function. If you have concerns about being able to hear or things like that, you can use the chat function, but otherwise post your questions to the Q&A module. With that, with no further ado, I will turn it over to Gabriel. Sorry.
It's okay. It depends on which part of the country you're in. Thank you kindly for the opportunity to present some of our work here in Calgary and some of our musings about how we need to do a better job integrating with public health. As mentioned, I'm a general internist, but I'm and a clinician in acute care and in outpatient settings, but a bit of a heretic, as all my work and research and a lot of the work that Annalee and I do are embedded deeply within public health. So I feel like the public health community is a second home for us, for sure. 6 months of Zoom. Okay, there we go. We study refugee health, so we have no disclosures. It's not a lucrative career option. Annalee and I co-direct the Refugee Health YYC program, as mentioned, and a lot of our research is done through academic grants that we take, that we write and take a lot of rejections for. We have, as mentioned, no disclosures. So just a brief overview. We're going to try to leave lots of time for questions and some hopefully make this more interactive as opposed to a boring webinar. We'd hope to give you just a broad overview of refugee migration and resettlement in Canada. We'll talk a little bit about the clinic that we have in Calgary, which is one of the longest continually functional specialized refugee health clinics in the country, and then talk a little bit about public health's role in refugee health. We can't talk about anything in 2020 without talking about COVID-19. So we'll talk a little bit about our experiences with COVID-19, and then at the end, we'll talk about a study that we're doing and our hopes to try to improve integration with public health in refugee health, and then save lots of time for Q&A. So I think it's hyperbolous to use the term migration crisis. Often it's used by xenophobic politicians that are trying to scare populations, this is my opinion, around hordes of invasions of refugees from around the world. That said, we really are in an unprecedented time of human migration globally. And these are a couple slides. So every year, the UNHCR, the United Nations High Commission for Refugees, releases its global trends report. And it showed that over the last decade, as you can see in these graphs, there's been an unmitigated rise that continues of forced displacement. So much so that the Lancet launched the Lancet Commission on Migration and Health, which is highly recommend if this is an area of interest potentially, has a really nice and comprehensive overview of all the health issues facing populations on the move. So some basic definitions when we talk about migrants. Oftentimes in the lay press or in the news, you'll hear the word migrants, which is a kind of an all-encompassing term. You know, Annalee and I focus a lot of our work on those that are forced to migrate, and that is the big distinction. The majority of migration into Canada and immigrants into Canada are entirely voluntary. That's over 90%, and immigrants, as everyone knows in the country, unless you are Indigenous or First Nations, everybody in this country comes from immigrants. And there's various categories: economic, business, family classes. We do have a growing proportion of temporary migrants, which are made up of our international students, and then increasingly temporary foreign workers and migrant workers, which certainly have been in the press with respect to COVID. On our side, we worry a lot about those that are forced to migrate, and that comes in two categories. In Canada, they're called, the distinction is refugee claimants. Sometimes in the US and in other countries called asylum seekers or asylum claimants. Those are those that folks that come to Canada and then arrive at our borders or enter the country and then claim asylum without being previously accepted. And then in the other category in Canada are referred to as convention refugees. And so the convention is the Geneva Convention and the Convention on Refugees, which Canada is an original signatory to that international convention in 1951. And those are refugees that the United Nations, that Canada accepts either through a privately sponsored refugee program or a government assisted refugee program or a blended program now. And they're previously accepted, screened and accepted prior to arrival to Canada. So when they arrive, they're accepted as permanent residents, as refugees. Those are convention refugees. So just to overview, in Canada, this is from the 2019 report to Parliament. We have nearly 200,000, or over, sorry, 321,000 permanent migrants that have come to the country. As you can see, the grand majority are economic and family class. And then we have about 45,000 refugees and a few other that are accepted under humanitarian grounds. Under temporary migrants, lots of visitors, which I think is tourism and visitors, but we have many student visas and a significant proportion, as you can see, 340,000 temporary foreign workers that come annually. As mentioned, the focus of the work that Annalee and I spend our time doing is on this small category in comparison to the broad proportion, which are refugees and claimants. So what is a refugee? This comes right out of the Geneva Convention in 1951. A person who's owing to well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, particular or political opinion is outside the country of their nationality and is unable to, or owing to such fears, unwilling to avail himself or herself to the protection of that country. And as mentioned before, we have the convention refugees that are recognized prior. These are the government assisted, the privately sponsored, and the blended sponsorship refugees. And then a significant proportion are claimants and asylum seekers that come to Canada. And among those, that proportion changes, but it's anywhere between 35 as high as 50% of those that make claims to Canada are accepted as refugees after going through the claimant process. So in Canada, the majority are, we take about annually with the United Nations, we have a target to take about 25,000 refugees as our obligation as a signatory to the convention. And in 2018, Canada was actually the largest resettlement, resettled more refugees than any other country in the world. And last year, and has been, I guess that was in 2018, supplanting the United States, but continues to be in the top 5 refugee resettling countries historically. And this goes back to since 1957 with the first organized refugee resettlement program for Hungarians in 1957. And here you can see, the majority of our refugees are privately sponsored, and blended visa office, those are half sponsored, half government sponsored. And another thing that we should be proud of is that, Canada invented the privately sponsored refugee program and has exported that to other countries around the world. And then you can see that about 18,000 are claimants who get of the 55,000 who made claims in that 2018 time period that were granted residency. These are the top 10 countries of claimants that were accepted in 2019. So you can see there's a broad swath. Although we are the largest resettlement nation in the world, it's only a sliver of the 26 million refugees, identified refugees in the world. We resettle about 25 to as high as 50,000 if you include the claimants in a year. And so globally, that is representative of the small sliver of those that are actually resettled. So about 2 or 3% annually are permanently resettled. And the grand majority of refugees are hosted in what we call host countries, which are often, not often, almost always low and middle income countries that that are adjacent to a country that's facing conflict or natural disaster or some what we call a push factor that's driving folks to migrate. So if the top country in the world is, if you think of source countries, Syria, due to its civil war over the last decade, continues to be the #1 producer of refugees. About 7 million folks have been displaced, and the top 2 host countries in the world, to no one's surprise, are Turkey with approximately 3 million refugees, and Lebanon, which has approximately 1.5 million refugees. And Lebanon being a small country, about 1 in 4 current residents in Lebanon are refugees or forcibly displaced. So by far have the highest per capita level, I don't want to say burden, but number of forcibly displaced migrants that they host. And this, one of the things about refugee health and these reports is that there are some countries that have protracted displacement factors, such as Syria over the last year. But this in our hands in Canada and at the refugee clinic, we have representation from over 80 countries, and the number and the countries and the blend and the diversity of the folks that we see each year change depending on push and pull factors. So why do we make these definitions and why does it matter for health? Well, one of the most important papers written in the immigrant and refugee health space was by Morton Beezer, published in the Canadian Journal of Public Health in 2005, where he coined the term the healthy immigrant effect. It was a really nice study that's been cited many times. And in it, he clearly delineates, or he shows that immigrants to Canada on swath using large data are healthier than the general Canadian population when they arrive. And then over time, that healthy effect over a period of time is reduced. But refugees oftentimes don't have that same healthy immigrant effect, and if lumped in with the rest of immigrants to Canada, it's often not seen. The reason is a selection bias. Canada specifically selects the most vulnerable as a policy, and we know that the simple fact of forced migration is bad for your health, and due to that, refugees often have much higher health issues than immigrants when they come to Canada. So who are the most vulnerable that are selected? So in about 2005, the Canadian government changed the policy to specifically try to target those that are of higher vulnerability. So women and girls at risk, survivors of violence and torture, such as our Yazidi refugee population, those that require family reunification who've been separated, those with very high medical needs or disabilities, and children at risk. And because of that, the refugees that the government selects, not in the privately sponsored program, but our government sponsored refugees, certainly have much higher health issues. Prior to migration, Canada has established a policy long-standing to have an immigration medical examination that is done prior, so for all refugees and immigrants. It's a physical exam, mental exam, review of medical history, and a few tests. The purpose of the exam is to, from a public health perspective, screen for communicable diseases of public health importance, also to screen for burden of illness, in quotation marks, that may be cause an undue burden to the social and health systems in Canada. And these are the tests that were done. It hasn't really been updated in over 20 years since the HIV was added in 2002. The Canadian government contracts out IOM, so International Organization of Medicine, physicians to perform these examinations and histories. And one of the barriers that we face in Canada is that the information from these examinations often doesn't make it to the hands of providers when they arrive in Canada. Refugees are not, so two important things with the immigration medical examination. Refugees, although they have to complete the examination, their eligibility for migration to Canada is not dependent on their health issues. Clearly, as one of the selection criteria for vulnerabilities is health issues or health needs. One of the public health mandates with the migration is that if communicable diseases are identified, so active pulmonary tuberculosis as the prime example that's used oftentimes, but COVID-19 would be another one in today's day and age, that refugees are mandated to see a physician within 2 weeks of arrival to address the communicable disease for public health protection of the Canadian population. Otherwise, refugees are under there's no obligation to see a physician or seek healthcare when they arrive to Canada at all. Despite that, in Canada, over time, there has been an organic development given the large proportion of refugees that we see each year across the country, that specialized refugee health clinics have popped up over time. One of the original clinics was Bridges Clinic in Vancouver, which stopped operations not so long ago. In Calgary, our refugee clinic was founded by a public health resident in 2003 in response to the influx of Sudanese refugees from the Darfuri crisis. And this is an incomplete list, but we have colleagues and friends and a network of refugee health clinics across the country that's quite active. So why do we need refugee health clinics? As mentioned, so on the left side, there's a high burden of neglected physical and mental health conditions simply due to the nature of migration. We screen for infectious diseases, they're complex, neglected chronic diseases that are not managed due to migration. We see a burden of undiagnosed congenital diseases, which I saw in clinic yesterday. We deal with a lot of trauma, both physical and mental, and as mentioned before, we start fresh without a lot of history or background. And then there are additional complexities for healthcare which make refugee health in our base fee-for-service model of primary care or in specialty care in Canada. There's issues with remuneration. So this is one of the places where the interim federal health program, which is a federally mandated program, and migration itself is in the jurisdiction of the federal government, although health and public health and healthcare are in the jurisdiction of the provincial government. So there are issues between jurisdiction. Some of our appointments are very long. We have large families that sometimes present, and we have to deal with a lot of issues on intake. So we have very long clinic appointments, which can sometimes, certainly are not adept for our usual care. We deal with low health literacy at times, illiteracy and innumeracy sometimes. We use often, I think 90% of our appointments are with translation, professional translation. By nature of resettlement, there's almost a ubiquitous poverty that comes with transportation and housing issues. There's a lot of intercultural perceptions around care and healthcare that we have to navigate. And then we do have to work hard to integrate with resettlement. We find that there's a lot of competing resettlement priorities. So for example, needing to open a bank account, get the kids in school, and still come back to the clinic to deal with some issues so early in the resettlement period requires a lot of integration. This is just a snippet of one of the studies that we've done that characterizes the diagnoses from a population of about 2,200 refugees from 2011 to 2017 in our clinic, from all comers, 76 countries. So as you can see, the top 10, these are just top 10 global conditions, and the ones I've put in the red box are quite specific to refugee health. So abdominal pain, we think, abdominal and pelvic pain is a surrogate, we think, for somatization disorders that are often accompanied with mental health and trauma. Number 6 is a neglected tropical disease, schistosomiasis, which my very first day in clinic as a resident made me so excited, but now we see it so routinely. Multi-drug resistant H. pylori, chronic benign neutropenias, hematuриas that we think are often associated with urinary schistosomiasis. These sorts of things are very, very common at the clinic, and they're mixed in with conditions that are very common. So nutritional deficiencies, back pain, hyperlipidemia, things that any primary care clinic would be very adept at seeing in Canada. So I'll hand it over to Annalee to tell you about the clinic itself.
Okay, well, thanks, Gabe. So as Gabe was just reviewing, the patients that we see, so refugees, have a high number of diagnoses often, and then they face numerous barriers to care. And so the Mosaic Refugee Health Clinic was established to help address those health issues in the outpatient environment, and helping patients access care by helping them overcome many of those barriers to care. So at the Mosaic Refugee Health Clinic, we see newly arrived refugees, all refugees. So whether, privately sponsored, government sponsored, or a refugee claimant, all are welcome at our clinic. And we see people shortly after their arrival. And then we follow them for their first 2 years, at which point we then transition them to their permanent medical home in the community. So in order to address the health issues and social issues that newly arrived refugees have, we have quite a large team. So we are a group of 21 family physicians, all have a passionate interest in global health. We all have additional training in tropical medicine, since most of our patients come from the tropics. We also work very closely with our resettlement partner, CCIS. So CCIS is the only refugee resettlement agency in Calgary. And that has allowed us to really provide comprehensive care to patients. So when refugees first arrive in Calgary, they stay at the Margaret Chisholm Resettlement Center for their first 3 weeks in Calgary. And within that resettlement center, we have 2 of our nurses. So we're able to assess and address their health needs immediately upon their arrival in Calgary. And so we're the team of family physicians. We have visiting specialists in order, again, to overcome a lot of those barriers when patients need to attend specialty care, which is usually at acute care sites. And in Calgary, it's incredibly difficult to navigate those acute care sites. And so the specialists come to us. And so we have psychiatrists, pediatricians, obstetrician, gynecologists, internal medicine specialists, infectious disease specialists, and a hepatologist. And then we have a very robust team of interdisciplinary team members. So we have a large group of social workers, several psychologists, nurses who act as complex case managers. We have a health navigator whose role it is to teach patients how to become independent navigators of our complex health system. We have a robust team of medical office assistants who help our patients with a lot of the logistics as well. So teaching people how to get to their lab appointment. We often at the beginning have to book people's labs and diagnostic imaging tests and teach them how to take the bus from their home to the office. We have public health nurses from Alberta Health Services that attend our clinic on Fridays in order to provide catch-up immunizations to the new arrivals. And then we have a person who's dedicated to transitioning patients. So once patients have the skills to be able to navigate the health system independently, then they meet with our transition coordinator to assess their needs, and then several options are provided in terms of the most appropriate clinic, and then patients are transitioned to their permanent medical home, and then they're followed up 3 and 6 months later to ensure that that relationship is working well. Next slide. And so the whole goal of the Mosaic Refugee Health Clinic is to identify and address any acute health concerns that people have upon arrival, to identify and manage any chronic diseases that people might have. We also address any mental health needs that might present themselves within their first 2 years. We provide screening for any infectious diseases or chronic diseases that patients might have upon arrival in Canada. We try to engage people in preventive care because often that's a novel concept for many of our patients. So a lot of our patients come from places in the world where you would only go see the doctor if you were sick. Why would you go if you were not sick? So they sometimes make fun of us in terms of prenatal care. Like, why in the world do I have to come every month, every 2 weeks, every week? When, back home, I saw no one, and then I delivered at home and everything was fine. And sometimes there's a lot of either stigma or false beliefs about certain screening tests or certain diseases. Like a lot of my patients from East Africa have told me that, they think breast cancer is only for white people, white women. So why would I get a mammogram? So there's a lot of education that way. And then we try over the first 2 years to teach our patients how to navigate the city and our health and social systems. And then once that is done, then we connect them. We do a warm handover to their permanent medical home. Next slide. And so the flow for the initial assessment at the Mosaic Refugee Health Clinic is a little bit, this is what it is in before times. It's a little bit altered in COVID times. So people, refugees, when they first arrive at the airport, they're greeted by CCIS staff who do COVID screening, provide hand sanitation, a fresh mask. If people pass the screening, they're taken to the Margaret Chisholm Resettlement Center, where they're then quarantined for their first 14 days. And so they're provided self-contained apartments for their first 14 days. They're provided a tablet and they're provided a telephone. And so they're connected to their resettlement counselor right away, and they do all of the initial resettlement work over the tablet or the phone. At the same time, our nurses who are embedded in the resettlement center connect with the patients or the new arrivals over the phone every day to check in on them and ensure that medically they are well and they're not developing symptoms or signs of COVID-19. And then while they're in their quarantine, we also provide them an orientation to the health system. We also do the first part of our intake history. So a physician will call them, do the initial history over the phone. And then once they're out of quarantine and are well, then they come to clinic. At clinic, we complete their physical exam. We do their laboratory tests. And then address any health needs that they might have and refer them to public health for vaccination. Next slide. Oh, next slide. Great. Okay, I think that's you, Gabe.
Yep, sorry. That's in the wrong order. My apologies. So places where public health integrates, this is like stealing all the thunder. This is supposed to be the grand climax of the talk. Public health, we work very closely with public health on prevention. So this is the best crowd in Canada to not have to make the case for why health promotion and prevention is the most cost-effective and most scalable way to approach health over a population. And in the acute care setting, oftentimes that could be an argument that we have to advocate for. There's as Annalee was saying, embedded throughout the first 2 years of the resettlement process is education. So health systems navigation, health literacy, health promotion, there's a ton of education with the goal of maintaining independence and integration. And then a lot of awareness, so working across multiple sectors. So as Annalee mentioned, and you could tell from some of the examples, addressing the social determinants of health, which are largely federally funded. So working very closely with resettlement partners across jurisdictional lines. And also today, I think it's really important that we talk about anti-racism, inclusion, addressing stigma, both within the communities, between the communities, and then between and within the general Canadian population, which, as everyone knows, is very diverse. Back to you.
Okay. So just in terms of the post-arrival assessment, so when an immigrant or refugee first arrive in Canada, there are guidelines published in the CMAJ developed by Kevin Potty from the University of Ottawa that outline the required or recommended screening tests. Next slide. And so our screening protocol at the clinic includes like a CBC and hemoglobinopathy screen because many of our patients suffer from thalassemia trait or beta thal or sickle cell disease or trait. They also frequently have nutritional deficiencies, and so iron deficiency is the most common, and that's the most important for children and their development and their ability to thrive at school. We screen again for HIV because we don't get the results from their IME that was done overseas, and so we again screen for HIV. Syphilis, we do the syphilis serology, looking not only for active syphilis, but also latent syphilis as well. Urine for gonorrhea and chlamydia. Most of our patients come from areas of the world with an 8% prevalence of hepatitis B. And so we screen for hepatitis B and hepatitis C. We screen for TB. So in their IME, they received a chest x-ray looking for active pulmonary TB, but we screen for latent TB. And we do that now, not through the TST, but through the quantiferon test. We also screen for parasitic diseases like strongyloides and schistosoma, which can cause complications down the road. We screen for varicella immunity in those over the age of 13. And if they're found not to be immune, then they're provided the vaccine. And then, of course, we do routine age-appropriate screening tests. So pap smear in those who are eligible, mammogram, hemoglobin A1Cs, et cetera. And then we do a stool for ONP and PCR, looking for stool parasitic infections that are quite common in children especially. So we do those tests in children under the age of 5 and in those who have symptoms such as diarrhea. Next slide. And so we're very fortunate to work closely with Alberta Health Services and have one of their public health vaccine nurses attend the clinic every Fridays to catch people up on their routine immunizations. Next slide. And of course, as Gabe was saying, most of our patients are young, they're in their childbearing years. They tend to have children during their first few years in Canada. And so when Gabe surveyed, did a chart review, we had over 500 pregnancies from 2011 to 2019. Last year alone, we had 72 births. So that's a lot of new Canadians being born. And of course, I don't need to convince this audience that having healthy babies is a good thing. Next slide. Oral health is the bane of our existence. So many of our patients suffer from terrible dentition. They're often in chronic pain, especially the children. And that chronic pain, it spills over into all areas of their life. And dental care is very hard to access, especially in Calgary. So the federal program, in the first year of their arrival, they're covered through a program called Interim Federal Health, which provides very basic dental care. So it will provide extractions. It doesn't provide cleaning. It doesn't provide anything more sophisticated than an extraction. And so addressing patients' dental needs is very challenging. And then once people graduate to a provincial program like Alberta Works, again, it's very challenging to meet the needs of patients, because there's often, for the problems that they have and the treatments that they require, it's often fee for service. So they'd have to pay out of pocket. And it's too expensive for most of our families. Next slide. And then, of course, we're identifying a lot of neglected chronic diseases in our patients. So prior to their immigration to Canada, they haven't often had access to care. And so they've often had chronic diseases that have not been diagnosed or managed appropriately. And so often we're identifying for the first time diabetes, hypertension, Parkinson's, all sorts of things. And some of my patients tell me, like, I was healthy until I got here. I started seeing you and now I've got 10 diagnoses. They tend to suffer from a lot of disability and musculoskeletal trauma just from their journey as a refugee. So often people have been involved in bombings or been involved in violent attacks abroad and are suffering the sequelae of that. And then also they've been exposed to other exposures like high levels of lead, often in their cooking implements, or high levels of fluorosis. So I think Gabe's and my, like the highlight of our life happened a few years ago, where we were able to diagnose one of our patients arriving from the Kakuma refugee camp who had severe musculoskeletal or skeletal abnormalities. We were able to eventually, after a lot of sleuthing, identify skeletal fluorosis as the root cause of his problem. And then we were able to publish the case in The Lancet, which then led to the UNHCR changing their water and sanitation practices in the Kakuma refugee camp, thereby affecting 180,000 residents there. So, so refugee health in Canada matters. Next slide. So COVID-19 and refugee health. So there's been a number of reports, one study in particular out of Ontario, which demonstrated that immigrants and refugees are disproportionately affected by COVID-19. One study in Ontario revealed that 43% of the COVID-19 positive cases were newcomers to Canada, whereas they really only represent 25% of the Ontario population. And so why is this? I think it has a lot to do with their social determinants. In Alberta in particular, like at our clinic, at the refugee clinic, we have a disproportionate number of people who've tested positive for COVID-19, and it's usually associated with their place of employment. So many of our patients work in the meatpacking plants and long-term care. And so they've been affected by their places of employment. Next slide. And so, like, I think just in terms of COVID-19, social determinants are always important to health. We all know this, but it's at no time has it been more acute than during COVID-19. You know, if we are unable to address COVID-19 within the newcomer population, then COVID-19 spreads to the rest of society, and it spreads quickly. And we've seen that in the Cargill outbreak. And I thought, instead of just going through like a list of social determinants, we'll just talk about a case. So one of my patients, her name is Asha, not her true name, but she was a 31-year-old single mother to 4 children. She's from Somalia. She came as a government-sponsored refugee. Her husband was murdered in Somalia. She fled to Kenya. She left her children with relatives in Kenya. She made her way to the Kakuma refugee camp. She eventually was brought to Canada for resettlement. After she came to Canada, she rented a room in a home with some other people, including an elderly woman with COPD. And she found a job at the Cargill meatpacking plant. She was immensely grateful for her job, that she makes $22 an hour working on the fabrication plant, shoulder to shoulder with other workers. She has very low English language proficiency. She has never had an formal education. She's had no skills training. And so she's incredibly grateful to Cargill for having hired her, because her job allows her to support her children back in Kenya. And she's saving to be able to bring her children to join her here in Calgary. So her job is incredibly important to her. And so when the pandemic first arrived in Alberta, the meatpacking plant offered incentives for people to work a certain number of consecutive shifts without missing a shift. And so she was thrilled. She was like, this is great. I get all this extra money for working. And of course, her being the hard worker that she is, she would never miss a job because she had a runny nose or a sore throat. It just doesn't make any sense to her. And she's not getting her updates on COVID-19 from our Dina Hinshaw, our public health system. She's getting her health information from friends and from her friends abroad and media abroad. And so she's not totally up to date on what the protocols and policies are in Alberta. And so when the outbreak first happened at Cargill, she was evicted from her home, not because she was sick, but because she's a Cargill worker. And of course, her being a newcomer didn't recognize that this is actually an illegal, an illegal act. You're not allowed to evict somebody because they're a worker at Cargill. And then the plant shut down, and she spent her time scrambling to find a new place to live because she's Somali and very resourceful. She found a place to live in another rooming house with 10 other people. Before she was set to move, her friend told her, oh, you need to get a swab if you're intending on returning to work at Cargill. They're requiring it of all employees. So she went and she got her test. And the day before she was due to move, she got the result, and it was positive. And so that's when I connected with her. And when I connected with her, she was panic stricken. She can't stay where she's at because she lives with a group of people and she can't safely self-isolate there. And there's people with vulnerabilities to COVID-19 there. She can't stay there. She's set to move the next day. She can't move to her new place knowing she's COVID-19 positive. She didn't understand the 10 days of isolation. How can she be 10 days without an income? How is she going to get groceries? She's a single person here in Calgary. She doesn't have any good friends that she felt like she could ask deliver meals. So she was incredibly panicked. And so we were able to resolve all of those issues, but that's just to give you a bit of a flavor of what individuals go through when they're a newcomer, isolated, living in poverty, living in crowded conditions in Canada. And luckily, because of our relationship with our resettlement agency, we were able to cover the cost of her rent at her current location so she could keep her stuff there. And then we were able to help her move afterwards, and we were able to set her up to safely self-isolate in a hotel, and then provide meal delivery during Ramadan. Anyway, okay, that's my, so I think it's a great illustration. And then as you can see, the mental health impacts of COVID-19 have been fairly profound. So just in that patient example, not only was she full of anxiety over all of these issues that she faced as a result of her diagnosis, she was also harassed by her landlord when suddenly she disappeared. He made the correct assumption that she tested positive for COVID-19, and then he was leaving threatening messages on her phone. A lot of our patients too, during the lockdown, again, when they've had, like many of our Yazidi refugees provide the perfect example. So lockdown, they were held in captivity in Iraq for years, and the lockdown, I think, was very triggering for them. So they felt captive in their home, and they had the same sensations as they had when they were in captivity with ISIS. And then they were left alone without any distractions. So they're left alone, their minds just perseverated on their past traumas, and their symptoms of PTSD really came to the fore. So I think in our population, we've been seeing a large spike in anxiety, depression, and PTSD. In addition, with a lot of our new arrivals, they don't have the IT skills to be able to access resources online. And now a lot of the newcomer centers, a lot of the resources that they need really require you to be able to access virtual platforms. And so people have been having tremendous difficulty. Thank you, Gabe.
Okay, well, here was the poorly delivered summary of why public health matters in refugee health. These are some of the solutions. I'm just conscious that I wanted to make sure there was time for Q&A, so I'm going to skip all the things. I did want to take a second to introduce a study that we are pursuing, that actually public health is 1/3 of the study and incredibly important. So this, as mentioned before, Canada has a 70-year history in refugee resettlement, but we have never properly characterized what our health system for refugees looks like in this country. And as everyone knows, we have 12 separate 13 separate health systems in the country. And in public health is this interesting place where we have crossed federal and provincial jurisdiction with PHAC and with migration. And so I am entreating, inviting, and begging the public health community. The purpose of this study, CIHR funded study, is for us to try to understand and characterize what is the integration of the primary healthcare services with public health and with the resettlement services in those three aims, to try to understand. We gave you tried to give you an overview of how we work with public health in Calgary and in Alberta, but really we have we don't really have an understanding of whether or not our experience in Alberta or the experience that we have with our colleagues at other refugee health clinics is the same across the country. And so I'd invite this community, and we will also be coming and pestering the public health community of Canada further to come to our website, refugeehealthyYYC.ca, go to /research, and then click this button down here that says take the survey, where we have it's a very short survey. It's about 20 minutes, and it has us to help us understand how public health works in your jurisdiction. Originally, the study was born out of the Syrian Refugee Initiative. The hope is to try to understand these three sectors in 186 jurisdictions across the country that resettle at least 10 Syrian refugees. And given COVID, we've updated the survey, updated the study. We really want to try to understand how COVID has affected the health system and how it's affected the integration of public health. And finally, when we finish that, the hope is to then publish an interactive map that's geocoded that will be open, freely accessible to all, so that that we actually can understand the structure and the processes of our healthcare system nationally, and that we can, that's step one in learning best practice and integrating across the country. So I'll stop to ensure that we have 10 minutes for questions, and there's a million. We have so many people to thank. The clinic, our institution, the funders, the Federal Ministry of Immigration, CIHR, et cetera, our Refugee Health YYC team, who worked very diligently to help us get this presentation together. And then there are our email addresses for Annalee and I, and we're happy to connect with you offline after the webinar, or to field questions or collaborations, ideas, et cetera. So I'll just stop there, and hopefully we've left 10 minutes for some questions if there are any.
Excellent. Thank you very much, Gabriel. I do it again. Gabriel and Annalee. I'm going to start with the question that I'll have you answer at the end, but I want you to think about it a bit. Question is, if you had unlimited power to implement policies at a provincial or national level to support refugee health, what would be your primary focus? So think about that. I think that's a bit of a thinker. So, so we'll start with the first question. Can you speak more to policies that are impacting the health of refugee women in Canada?
Lee, do you want to go?
Sorry, I was just reading. I was answering the next question there. I was just typing in the box. Policies. You go ahead. You're more the policy wonk. Policy.
I think, yeah, in broad strokes, I think we would do, Pareto principle would be, can we pick a few things that would have high impact? I think integration across federal and provincial boundaries, so migration with health, and I'd go so far as that would be my number one pick to your first question. So it makes no sense to me whatsoever that we contract out IOM physicians that do a lot of work beforehand, that we meet at international conferences, and then are absolutely appalled that all of their hard work never gets into the hands of practitioners on the domestic side. So this is agnostic to sex or gender. I think that would be one absolutely easy fix. With respect to women, I think that I'm very proud that that there are policies. So speaking of policy, that we specifically The government specifically targets women and children that are at risk, that are highly vulnerable. We know that the gender and sex inequities globally are massive. And we live in a country that, despite having our own inequities, is a safe place for women and girls. I think that is a policy that's laudable. I think things that we can do better post-arrival are connectivity. So on the ground, policies that I think that we can strengthen. And one of the things that Annalee and I in our research program that we focus on is how do we work better with the resettlement and social sector to deal with the social determinants. And so empowerment for women and girls, community building. So our Yazidi women as a perfect example of one of the most traumatized groups we've ever had. And Annalee is an absolute champion in this regard. It worked very, very hard to integrate mental health, resettlement, and healthcare together that were very tailored to women and girls that faced extreme violence. So I'll just stop there, but I think those are two things that would be really helpful. Would be further integration with federal migration, just information sharing. I think the policies that currently exist in terms of targeting vulnerable women, I think are good and laudable. I think they're relatively unique globally. And then I think post-resettlement, post-arrival, I think we can all just do a better job as not just in refugee health, but writ large, is further integration with services that would address the social determinants and that are tailored.
Great. Next question is, abdominal pain is not a diagnosis. What are the underlying causes?
Yeah. That is a difficult question to answer. Do you want to try? Like, we've tried to go through that.
The truth is we don't really know. Like, I think it's written in our charts. It ends up being written as like abdominal pain NYD. And I think it's actually it's often a somatic symptom. But we haven't really done that deep dive into the charts to determine the real reasons why. So I don't think we really know.
Yeah, agreed. We haven't been able to dig into it, but
that's an acceptable answer. Why is there no refugee clinic in Edmonton?
There was one.
So there was one, and it was shut down by Alberta Health Services because they didn't see the value. And so anyway, there's a team working on it right now, and like Alberta Health seems very interested in supporting. So Alberta, how there's a difference between Alberta Health and Alberta Health Services. And so previously the clinic in Edmonton was supported by Alberta Health Services. And so our clinic was never supported by, in any large part by Alberta Health Services. And so that was very helpful. And so we couldn't be cut by them, but in their goal of reducing costs, they cut that refugee clinic just before the Syrian surge. And I know that they've struggled quite a bit in providing care to their newcomers. And so there's a very active team in Edmonton who's working with Alberta Health to develop a new refugee clinic. And it seems to be moving along, and it seems to have the support of the ministry and the Minister of Health. And so it's very promising. So stay tuned.
Excellent. So I'm just aware we're approaching the top of the hour, but Annalee and Gabriel, do you have time to continue for a few more minutes?
We were a bit over, so I'm happy to stay to answer
Excellent.
questions.
So for our participants who can stay on, we will continue to answer some questions. So can you expand on how you teach navigation of healthcare systems, as I suspect your knowledge of what works is also transferable to other patient populations?
Mm-hmm. So I'll speak to it at a health services level, and then Annalee, maybe you talk about the details at the clinic. So I'm very interested in health navigation as a bridge. So in my research training and in global health, there's increasing examples globally of community programs of community health navigators, community health workers that are really, when integrated well with the health system, can extend care out to the community. They're very empowering. They're built within communities. They deliver education from trusted sources. They provide economic and educational ladders. I'm involved in 2 other interventions that work on navigation and community health and navigation programs, one in the chronic disease, the other in our patients that experience homelessness in Alberta and in Calgary. And at least in the latter one, we have compiling data and analyzing data that shows that these can be highly effective to improve care and cost effective. I think it's one of the missing gaps in refugee health, and there has been some movement nationally in the last round of innovation grants from IRCC to address some of this, but maybe Lee knows this inside out within like a granular context in Canada and Calgary.
Well, I'm just more on the ground. And so just for us, like what I think it requires is it's the same as medical residents, see one, do one, teach one. So people physically need to be taken by the hand and showed how to get to wherever it is they need to go, like how to navigate the hospital to find the outpatient clinic, how to access like a program at some social service agency. Like they need somebody to physically go with them. And so there are community health workers who will do that. There's also like CCIS has a group of complex case managers who will do that, and health navigators who will do that. So the resettlement agencies have the resources to be able to do that with people now. And then we have to do it as well, like at the clinic. One of our health navigators will teach them, and sometimes they will have to show them how to go. So, and through our social workers, like we educate people, like what are you eligible for in terms of income benefits? What are the housing options? And physically, luckily where we work, most of what we need is actually housed in the same professional tower. So if people need to go to Calgary Housing, which is our subsidized housing program, it's downstairs. So we're actually able to just physically take them by the hand and make those introductions. And a lot of our health partners, so like dentists and audiologists and podiatrists, et cetera, they're all within the same, optometrists, they're all within the same tower. And so we actually can physically go with them. And we often have to go with them, like when they first come, we physically have to show them the pharmacy and how to fill a prescription, because it's usually very different in Canada than it was in the host country or their home country. And so we physically go and we show them, you stand here, you give in this piece of paper, then you wait here, and then they'll call your name, and then you pick up the medicine. Like I believe in the warm handovers and the warm introductions and teaching people. And then refugees are incredibly resilient. So once you teach them, once they're taught, they're good. They don't have to be taught again.
That's great.
So it's initial investment, right? An initial investment to get them on that healthy foundation to build their lives moving forward.
Super. Next question, actually a few questions bundled together. I noted that you mentioned that your services include social workers and psychologists. Are any systematic assessments of mental health and well-being being done on the mental health and well-being functioning of the refugees you serve? Question 1. Question 2, do you have any statistics addressing this issue? Question 3, have you looked at LGBTQIA, Two-Spirit Plus refugees and mental health and resilience in any of your research projects? And 4, little add here, are you interested in starting research collaborations on this topic?
Always interested. So I'll take the research questions. So there is, whoever asked those questions is absolutely, I am sure, knowledgeable the dearth of data that exists. One of the things I'm really proud of in Canada is the Rainbow Railroad. And so we had an influx prior to COVID, somewhat prior to, but kind of embedded within the Syrian refugee surge was, identification of refugees with vulnerabilities. So in Cameroon, for example, it is illegal to be gay or to be of the LGBTQ2 community, and so we have many patients that had to flee for their lives for no other reason than that. There is a dearth of data because intake, it is not routinely collected in any administrative data, and so we've worked to create and implement our own intake survey that so in our research, we essentially build in data that is then collected retrospectively. And so, yes, 100% interested in pursuing a subpopulation. We have a patient advisory committee that we specifically invite members that are broadly representative, so of the LGBTQ community, who are they're empowered advocates, and they embed themselves to help us direct our research. So that's how we've been working to include them. Third, we know that mental health is a massive issue within refugee health. So we do have a study that we're finishing up and submitting relatively soon that summarizes all of the health conditions over that 2,200 refugees that you saw over that period of time. And mental health is a significant, obviously a very significant, and it's often underreported because we don't routinely screen for. There's one screening tool that's specific to refugees in the literature. There is debate in the community, in the refugee health community, whether or not we should be screening because it's quite triggering. In our personal, in our work in Calgary and some of the refugee clinics in Canada, we don't actively screen. We wait until relationships are built and trust is built, and then we find the mental health issues. Then they come naturally. And then there are data. So specifically mental health, the best and most cited is a systematic review from the Lancet that showed that approximately 35–40% of refugees have post-arrival refugees in high-income countries have active mental health conditions, anxiety, depression, PTSD, the most common, and that's probably underreported due to lack of screening. So we try to use a holistic approach. As Annalee mentioned, a big part of that, the mental health supports is integration with full teams and communities, our psychologists, our psychiatrists, our primary care providers, et cetera. And then we all, as an internist, it's out of my field, but I've had to do a lot of extra training in mental health. So everybody in the refugee health world has to have extra training in mental health and cultural competency to be able to do the work because it's so prevalent.
Yeah, and I would just reinforce that a lot of mental health can be mental health, like well-being. Mental health is a bit different than mental illness. So not everybody has a mental illness, but mental sort of one sense of well-being is often compromised and can lead to mental illness if those social determinants are not addressed. So if people we can't help what happened before, but we can help what happens in Canada. And the best way to help our newcomers in Canada is by being a welcoming society. So without racism, without stigma, with stable housing, stable financial security, food security, and good social networks. Like I'm sure like if we were able to address those social determinants, the I'm sure a lot of people's struggles would resolve. But we don't. Like, unfortunately, our newcomers, especially those from racialized communities, they suffer from blatant racism within our healthcare system, as we know, out on the street. They have very poor quality housing. They can't meet their bills. They don't have a lot of educational or employment opportunities, and all of that creates chronic stress, which will then eventually could lead to mental illness down the road.
Great. Next question is, any concerns from patients regarding post-screening tests?
I think it depends on the population. So one of the things that I'm cautious of is to, we use the definition of refugee because, or, refugee claimant because of forced migration, but sometimes that's the only commonality that people have. So if you can imagine, we have, over 90 countries in the last decade or 15 years represented at the clinic. And so some communities and cultures have significant concerns about stigmatization. So one specific diagnosis is the stigma associated with HIV, stigma associated with TB, stigma associated with some of the illnesses, whereas others, the Middle Eastern population, so the Syrian community, chronic diseases are quite prevalent in the middle income countries. And I might personally find, and there's reports in Canadian literature about Syrian refugees being very empowered to seek and ask for comprehensive care for chronic illnesses such as hypertension or diabetes. So there are some, but it's very difficult to, I think in my opinion, it's very difficult to make any generalizations because the population we serve is so incredibly diverse. And there are probably some commonalities, and there's probably a lot of diversity based on culture, region of origin, et cetera, et cetera.
Okay, great. The next two questions are very similar. So they're asking, can you speak about the health promotion work in stabilization of chronic diseases? And conversely, other than screenings, what preventive measures do you use for the refugee population?
Mm-hmm. Do you want to go?
Yeah, it's all about education and getting them engaged in the greater community. So, like us as a clinic, we don't do that work except make those referrals. So the newcomer agencies, the schools, they do the bulk of that work. But I do, usually talk to people like, don't become Canadian, like don't become like this population where we suffer from diabetes and hypertension and high cholesterol, and we're dying of heart attacks, et cetera. So like I encourage people to not sort of eat fast food, like a lot of because it again, it all has to be individualized, but encouraging people to maintain their cultural food traditions. And in a lot of our patients, like, Pop and McDonald's and Kentucky Fried Chicken, it's like a sign of prosperity. And so they'll often start eating those foods. Not only are they cheap, but there's a bit of a like status associated with it. And so I just talk to people about that and then get them engaged in recreation, especially the children. And luckily our resettlement partner, they do have soccer teams for the youth, and different activity groups. And there's different, there's the Bridge Foundation. There's all sorts of different foundations and groups where they will engage children in recreation. And again, it establishes a social network and a sense of belonging. And with adults, there's different, in the Northeast, there's a bunch of different programs. Of course, everything's like a little bit up in the air because of COVID, but there's different walking programs and physical activity programs through the Mosaic Primary Care Network where I work. And so just getting people involved in those types of activities and talking to them about healthy diets, that's what I do in the clinic.
Excellent. Question, why is dental care specifically challenging in Calgary?
Actually,
they're not us. Like, I don't know. They're not sort of, there's not a big global health. I don't know. Like I will
I
say,
think that's a national issue. So dental care is outside of the healthcare system traditionally, and so
but
part of
Quebec, it's not true.
yeah,
Like in
that's
Quebec,
fair.
you have free dental care until
That's
you're
fair.
an adult, until you're
That's fair.
18, 19.
Yeah.
Whereas in Alberta, you do not.
Yeah.
And it is very much like it is the most expensive fee guide in the entire country. And it is it's incredibly expensive. And so, and it's just not covered under our social programs in any great extent. And so people are left to suffer. So I had a patient this summer where her dental abscess extended down her neck and she was
I know.
admitted to Foothills Hospital for IV antibiotics, and she
I
still
have,
had a draining abscess. So and I can't get her
yeah, I
the
know.
care that she needs because she needs dental work that she can't afford. So
One of the reasons we're trying to pursue that study is to understand these types of issues and where the heterogeneity exists. You're right. In Quebec, it's covered, but in many other provinces, it's not. And you're also right. I don't know how many people I've admitted under my care in the hospital with endocarditis or other incredibly expensive and difficult conditions that are entirely preventable with dental care. So again, it's in our prevalence study, it comes up as one of the most highly prevalent group of conditions that we deal with. That part of understanding and doing the prevalence work is to highlight or understand that there is a need there, and then that's step one. And step two is then looking at policy options. That if we're looking at again, the public health community knows this. Promotion, health prevention is the best and most scalable way to do anything. And so that's kind of the hope of doing some of the research, is to understand that as a foundational step.
Great. Unfortunately, we have run out of time. We still have a ton more questions, but thank you very much, Annalee and Gabriel, for a tremendous presentation today. Obviously, a topic of huge interest to the audience, given the number of questions. You did provide your email addresses, so it's on you. You encourage the audience to contact you directly with your questions. So I want to thank you so much for being with us today. And I want to thank the University of Calgary's O'Brien Institute for Public Health and Department of Community Health Sciences for their support of today's webinar. As I mentioned before, the session was recorded and will be posted to CPHA's YouTube channel in the next couple of days. And you will receive an email from CPHA webinars at CPHA when that is accessible. Thank you all very much for participating in today's session. Take care of yourselves and be kind to each other. Goodbye.